Okay, so here is a quick overview of potassium regulation. So potassium is the major cation in our intracellular fluids, with only a small amount found in our plasma and our interstitial fluid. Our normal serum potassium levels are 3.5 to 5. And our ratio of intracellular to extracellular potassium, it must be maintained for neuromuscular response to stimuli. So potassium is a vital electrolyte for skeletal, cardiac, and smooth muscle activity. It also must be ingested daily because the body does not conserve a whole lot of it. So many fruits and vegetables, meat, fish, and other foods contain potassium. So some different things that can lead to hyperkalemia. So tissue trauma, chemo, or aged transfusions. This can lead to hyperkalemia because remember, most of the potassium is contained in the cells. So anytime we have cell damage or cell breakdown, those cells release their potassium into the body fluids, which causes hyperkalemia. Now the biggest issue with hyperkalemia is the cardiac changes. So our cell membrane potential is altered, which means that it's easier for cardiac cells to reach that firing threshold. So your heart basically becomes really irritable, which is why we see our EKG changes. Some of our other smooth muscles also become hyperactive, while the skeletal muscles weaken. So what happens when your smooth muscles become hyperactive? That's going to lead to like vomiting and diarrhea. At the same time, your skeletal muscles weaken, so you're going to have the muscle weakness or the flaccid paralysis. There's several things we can do to treat hyperkalemia. We may give some calcium, which helps to lower the resting membrane potential in the heart, so it's going to make the heart less irritable. We give K-exolate, which is something that you take PO and it binds to potassium in the gut, and then you poop out the extra potassium. Then we have insulin. If we give insulin, it pushes potassium into the cells. But we don't want the person to become hypoglycemic, so if we're giving insulin, we also need to give glucose to maintain their blood sugar level. Some diuretics, we might give some potassium wasting diuretics like Lasix, which helps the person to just pee out the extra potassium. We may give a beta-2 agonist, so something like albuterol. So in the body, catecholamines, like epinephrine and adrenaline, they increase the activity of a protein known as sodium-potassium ATPase. So when this protein is activated, it pumps potassium into the cells while also pumping sodium out of the cells. So that's our sodium-potassium pump. So albuterol is a beta-2 agonist. This means that it's able to bind to and mimic the effects of adrenaline on certain cells, including its ability to trigger the transport of potassium out of the blood and into the cells. So essentially we give albuterol because albuterol also works to move potassium from the extracellular space into the cells. Sodium bicarb we're going to give to help treat acidosis because hyperkalemia and acidosis go hand in hand. So hyperkalemia impairs the acid excretion in the tubules of the kidney, so we might need to give some sodium bicarb to help combat that acidosis. In severe cases, we may actually need to do dialysis, where we will physically use our dialysis machine to remove potassium from the bloodstream. With hyperkalemia, it's really important to keep a close eye on cardiac activity. So our patient needs to be on continuous cardiac monitoring. We also want to look for symptoms such as that skeletal muscle weakness or that smooth muscle irritability. So we're going to monitor our eyes and nose. We're going to check daily weights. And we're going to do at least daily or multi-daily labs. Okay, on the other side we have hypokalemia. So this is when we have too little potassium in the body. So one of the causes is potassium wasting diuretics. So that person is peeing out excess potassium without replacing it in their diet. Corticosteroids can also cause kidneys to excrete more potassium. Some of our antibiotics, like amphotericin B or penicillin, in high doses can cause hypokalemia. Any severe vomiting, gastric suction, or loss of intestinal fluids. Now, okay, remember we have to ingest potassium because it's not stored in our body. So if you're having vomiting, you're having diarrhea, you're undergoing suctioning, you're not going to be able to ingest or absorb that necessary potassium. An insulin excess, remember insulin pushes potassium into the cells, which makes it unavailable in the extracellular fluid. So if you have too much insulin on board, you may actually get hypokalemia. Of course, inadequate intake if you're just not taking it in your diet, or if you have alkalosis. So hypokalemia is both caused by and results from alkalosis because hypokalemia causes an increase in renal acid excretion. So our symptoms are actually pretty similar to hyperkalemia. We're going to see ECG changes. And in this case, the heart is going to be less likely to fire and will actually slow down. So bradycardia is going to be common. We'll see the nausea, the vomiting, the anorexia, the decreased bowel sounds, maybe an ileus. Again, we have decreased cell firing, which leads to decreased bowel motility. We have muscle weakness and leg cramps because of the disturbed function of our skeletal muscles. We may your body may reduce the amount of insulin it's secreting, so it's going to secrete less insulin to try to prevent the push of potassium into the cells, which also could lead to hyperglycemia. And then we may have a reduced ability to concentrate urine, and this appears to occur because hypokalemia causes defective activation of renal adenylate cyclase, which essentially it just prevents antidiuretic hormone urinary concentration. So we just have this reduced ability to concentrate urine, and we just start kind of peeing like crazy or having to go very frequently. So with hypokalemia, again, we're going to monitor our labs. We need to monitor our heart rhythm, and we're going to check ABGs to watch out for that alkalosis. And then we're going to use medications to replace the lost potassium while we identify and treat the underlying cause. So there's lots of different types of potassium medications, but potassium chloride, KCl, is usually the most common that we give. So potassium can come PO or it can come IV. If it's given IV, it is heavily diluted, so usually not more than 10 milliequivalents in 100 mils. And that amount needs to go over at least an hour. So it's common that we're going to give 40 milliequivalents. This would need to be diluted in at least 400 mils and needs to be given over at least 4 hours. So to avoid potassium intoxication, we do not give these rapidly. And in patients with renal insufficiency, the administration of potassium chloride can actually cause potassium intoxication and a life-threatening hyperkalemia pretty quickly. It also burns as it goes in, which is why it's very heavily diluted, and we like to give it through a central line if possible, and if not, it needs to go through the biggest peripheral line that you can get into your patient. Again, it is never, ever pushed, IV push, or as a bolus. It is given slowly and heavily diluted and always, always on an IV pump.